Thank you very much. Thanks a lot, Mahar, for the invitation. It's great fun to be here in Vegas, especially since we're having a small University of Louisville reunion. Unfortunately, I have no disclosures at this point. And I come from University of Louisville. There is a most exciting 2 minutes in sports, Kentucky Derby. Then place where the first artificial heart was implanted in a patient and first successful hand transplant, and also place of Muhammad Ali's birth. So we have this magnificent Muhammad Ali museum that shows not just his sports accomplishments, but also his struggle for human rights. So I would definitely encourage any of you that ever pass through Louisville to stop and check out this museum. And also in the University of Louisville, some 30 years ago, I was the first one in the world to start teaching anatomy and laparoscopy on cadavers, not anatomy, laparoscopic surgery on cadavers. So I used to take our residents in the cadaver lab and suspend the abdomen to the ceiling and steal the laparoscope from the operating room and do these surgeries. And then we started the AGL course in minimal invasive surgery on cadavers that was now running into its 25th year. So some thoughts to consider is that minimal invasive surgery does not mean minimal risk. Laparoscopy is not a procedure, it's just type of access, and it's important also to know its advantages and disadvantages. And there are a lot of people that talk about complications of laparoscopy, and they usually talk about somebody else's complications in this lecture, which is good. Probably would have been better if we had it after lunch, because some of these videos may make you lose your appetite. So they are all, unfortunately, my complications that I've incurred over 30 years of teaching residents. So when this is the first test to see if my sound works, great, yes, okay. So very often we are in the operating room and we're getting these extraterrestrial signals that we tend to ignore, and because we are focused on one thing. And unfortunately, if you don't want to be run by a truck, you gotta pay attention to all these details. There are two ways to screw up during surgery. One is disregard of anatomy, and the other one is disregard of techniques. So I'm a great driver. I would be worthless here in Las Vegas being a cab driver. So you don't want your cab driver not to know the streets. At least now they have GPS. But the surgeons don't have GPS, so you let somebody operate, and if they're not really very good with retroperitoneal anatomy, you know, that's the way to get complications. The other way is to disregard the technique. And here, this video, which is anonymous, I have no idea who did this. I hope it's not anybody in the room here. Actually, it's a very old video, 30 years ago. So you have a surgeon that now presumably is trying to operate on endometriosis. We're dealing with the pelvic sidewall on the right side. So he's finally, on the left side, sorry, finally identified the area that he or she thinks it's endometriosis. And you're looking here, some of you can already recognize that and so he or she, the surgeon, is using right technique, bipolar, dealing with the bleeder, taking out there is some residual bleeder, taking out the specimen, only to then realize that they have removed the external iliac vein. So the important thing with complications is to actively seek the possible complications that can occur, because when you look at the litigation and complications, the majority of the lawsuits are because improper prevention, inadequate recognition, and delayed intervention. So it's okay to have complication to get, and I personally have been in every cavity in human body, not by choice, but at least we have recognized it and we fixed it. So The key is to recognize the complication. Sometimes it is inevitable because the disease is so close to certain structures, so that it's okay to get into the bowel, but if you get into it, you have to recognize it on time and fix it. And so the major vascular, actually mortality rate is for vascular injuries. It's 9 to 17%, but majority of them were unrecognized. So that's the problem. The blind entry is also a problem. So the Chaperon did a great study in Europe when they recognized one of 3 complications was in very early stages of surgery. And that's still, for myself, after 30 years of doing laparoscopy, the most anxiety part of the surgery is getting in, because that's kind of blind part. And once you're in, then you're pretty much in control of the rest of the thing. One of the 4 complications was not recognized, which is really bad. And then they also tied to complexity of complication. There is less chance you're going to have serious complication doing tubal ligation than if you do resection of 4-stage endo. But as you will see from my videos, some of my worst complications happen actually during tubal ligations. And then surgeon's experience is a very important factor. And also from the same, they looked at the increase in bowel injuries, and the more experienced surgeon, less increase in bowel surgeries. And then also the more experienced surgeon, they had complications that required less laparotomies, and they were able to fix it laparoscopically. But now the question is, who is the experienced surgeon and who is not experienced surgeon? So we take these standards from airline industry. They say you have to fly 10,000 hours to be experienced pilot. So we just applying the same thing and saying 10,000 hours to be a good surgeon. So the question is, would you trust this pilot? I got the uniform and the badge, somebody else's badge. So do you understand this? Do you know this guy here? It's okay, one hand, all right, that's good. Doctors don't read books, I understand that, 2 hands. All right, so this is, if you ever get a chance, buy or whatever, you can go and even listen to the podcast of Malcolm Gladwell, the New York Times bestseller list, that wrote this book, that was his first book, Outliers, that shows why successful people are successful. So he takes the example of Bill Gates, Rolling Stones, and so on. Beatles, actually, they played for entire year, Beatles, for instance, in Hamburg, Germany, that was Las Vegas of the time, where they played for literally food and sex and drugs, and for a year before they became Beatles. So the key is you have to be prepared and be good enough and find yourself in a certain situation where you really become good and famous. So try to get that book and read it. And here's the interview.
And you talk about the 10,000 hour rule. That it's not just a matter of, well, this person's a genius, this person has an amazing ability. It is actual practice and hard work.
So a group of really brilliant psychologists in the field of expertise research have sat down and tried to figure out, how long do you have to work at something before you become really good, right? And the answer seems to be, it's an extraordinarily consistent answer in an incredible number of fields, and that is, you need to have practiced, to have apprenticed for 10,000 hours before you get good. So every great classical composer, without exception, composes for at least 10 years before they write their masterwork.
Mozart, 10.
Mozart is composing at 11, but he's composing garbage at 11. I mean, he doesn't produce something great until he's 22 or 23. Concerto number 9, I think, 271. If I asked you, how long did it take you when you were doing this job before you felt comfortable and good at what you were doing?
10 years at least.
10 years, yeah. Same with me. I mean, it's an incredibly consistent finding, and it's really important because it says that we are far too impatient with people. When we assess whether someone has got what it takes to do a certain job, we always want to make that assessment after 6 months or a year, And that's ridiculous, you know? The kinds of jobs we have people do today are sufficiently complex that they require a long time to reach mastery. And what we should be doing...
So good news is that you don't have to be a genius, but bad news, it takes time to become good at something. So there are certain risks for patients that undergo laparoscopic surgeries. Those are first patients that had previous abdominal surgeries, because they're going to have lots of scars, possible adhesions. So when you get in, you may do some damage. Then there are difficult and complex laparoscopic cases, as I mentioned before, and patients with low and high BMIs. And especially in Kentucky, we have patients with a lot of high BMIs. But those with the low BMIs, we have very thin patients. You put your hand on her belly and you can feel that aorta pumping, so it's kind of, you know, stressful. So complications can really become from any part of laparoscopic surgery. Something as very benign and simple as patient positioning, the equipment, insufflation technique, electrosurgery. We all doctors, we have no clue how electricity works. So we get an instrument in your hand and you start firing and burning stuff, and you don't really know how the physics behind it. Then something that can be very grave is trocar placements to the vascular injury, bowel injury, and so on. And so the most important thing, again, is to recognize them on time. Positioning of the patient is very important, so you've got to put the stirrups in a position so that the legs and nerves are not overstretched. You need polycatheter so that the bladder is emptied, and then make sure the patient doesn't slide during the procedure, during the steep Trendelenburg procedure. I've operated all over the world, and in US it's very good because anesthesia is really good. They let you tuck the arms, but in most places around the world they don't really let you tuck the arms. So if you operate like this, you're not going to be able to go to the retirement age on the golf course, but you'll spend it going to the chiropractors, or you can successfully sit on patient's arm, which wouldn't work well either. And the timeline for complications is very important. Right after surgery, you're going to have vascular complications. That means you're going to have bleeding, if apparent. So checking hemoglobin hematocrit is important to get those on time. 2 to 3 days, you may have urethral injuries, and by checking creatinine and IBP, you can get the correct diagnosis. Bowel injuries, if you have just like a thermal injury to the bowel, it may be apparent a week later, but if you have a direct hole in the bowel, it may become apparent next day. I also do a lot of medical legal work, not a lot, so if you have any cases, just kidding. So from time to time, and where I see the patient, the doctors fail the most in recognition of these injuries. So you have a patient that had surgery, they get him in they come to the emergency room, and instead of doing CT with contrast, and right away, you know, they wait, they look, you know, left and right, trying to find every possible excuse, and that's where you fail, and that's where they get you. So the most important thing is also to think about the timeline of these complications. The further away from surgery you go, all these bleeding, bladder, urethral injuries, all of them, there is less chance of them occurring. And then also during surgery, this slide should have been earlier, I didn't check it. You know, you are the captain of the ship. You cannot rely upon your circulator or upon your nurses. You should know every button and every button on these instruments, how they work. At one point I used to operate in 4 different hospitals, and they all had different equipment. Now luckily I just work in one. And also in the old days we used to improvise a lot. You could, you know, there were not gadgets for everything. Now there is a gadget for almost everything, and you cannot improvise. So you have to take this very seriously. Another thing is I always film all the surgeries, because I think for 2 reasons. First, it's going to help me a lot in like situations like this here, and I swear to God this is a 4th year resident. See, he's cutting the abdomen. He's cutting the uterus, the colpotomy, and then he touches with the instrument the bowel. Luckily, he took away foot off the pedal, so nothing happened. And the second thing is, if the patient is not doing well, then we can go back and take a look and go through the entire film and make sure that we haven't missed anything, because very often you are concentrating on one thing and then you're missing the whole forest from the tree. So the key thing is always be concentrated, not like this guy.